Hello, everyone, and thank you once again for inviting me for this second time in the international workshop on US and mediastinal EBUS, Combined Society for Mediastinal Adenopathy Diagnosis. So, myself, Dr. Kishan Gonuguntla, I'm an intervention pulmonologist at Yashoda Hospitals, Hyderabad. My topic is on endobronchial ultrasound and what are the new techniques of tissue acquisition at this point of time. So as we all know, EBUS TBNA is the current recommended first best choice for staging the mediastinum. Not only staging the lung cancer, but also in diagnosis of other intrathoracic lymphadenopathy conditions like sarcoid, TB, lymphoma, and metastasis from other areas. EBUS has already proven its role as the prime choice for intervention pulmonologists. So a lot of factors will decide how good the diagnostic yield is, and also how good the molecular markers analysis is when on an EBUS TBNA. So quantity and quality, cellularity and purity of EBUS TBNA needles play a very important role for diagnosis, also for comprehensive evaluation of patients. The common variations are, if you look at in EBUS needles, so we have so many needles, and the common differences between them are the major difference comes with the handles, actual needle design. Some have core traps at the end of the needle, some have a standard tip at the needle. And then regarding the size, we have ranging from 19 to 25, we have different gauze needles available. And then some differences we can notice in the locking mechanism. Some have an adaptive walls and some have rear lock mechanisms. And the material also, like some are made of nitinol and some are made of cobalt cobium. So we will, in this short discussion, we will see if these things can make a difference in increasing your diagnostic yield, or can they make a difference in getting a better tissue when you use a different needle, or when you use a different company needle, or when you use a different model needle, like where the tip is having a core, or when the tip is having a blunt end. So already we know that there are some established facts in EBUS. So suction versus no suction doesn't make much difference if you use or not. Size really doesn't matter as per the meta-analysis, but the more larger the size of EBUS needles, the larger blood contamination happens. That's a proven fact. And small gauge needles are proving to be more beneficial by lessening the contamination with the blood. And if when you look at rows versus no rows, maybe doesn't make any much difference in diagnostic yield, or maybe you can speed up your procedure if you use rows in your. It's an additional tool, and more than 3 passes may not yield much to your diagnostic yield. So these are all proven, established facts in EBUS TBNA. So why there is a need for new techniques of tissue acquisition? So whatever said and done, still there are certain demands that need resolution in EBUS TBNA. We are not comparable in the diagnostic yield when it comes to CT-guided biopsies or any other procedures, which almost more than 95-96% of diagnostic yield. So we will discuss like what are the demerits of EBUS TBNA with the current available technologies. So with some scopes, there are false negative rates of EBUS are mainly due to the inability to sample a few stations because of the fraction capabilities of these scopes. And also difficulty in sampling certain stations, especially those stations like 4L node. Things that will hinder getting into the node for the intervention pulmonology sector. So needle stiffness, lack of flexibility, suboptimal sharpness of these needles, they do play a role affected by the needle size, but more bloody contamination definitely will have some impact on the genetic profiling. So we have two different types of needles in the 25 gauge. From the Boston Scientific is called an expectium, and the other one is the Ecotip Procore needle, which has a lateral bevel designed to cut and then get the tissue out. So there is increasing body of. We also have to, though the needle sizes are increasing and the scope sizes are coming down, slide is sufficient to make a genetic profile on an EBUS TBNA sample. So what are the new emerging techniques or which evolving in terms of ultrasound, endobronchial ultrasound, a bit more than the gastro side in these techniques? I'll explain. So size already is being discussed in the gastro departments. So lot of difference between these 19 gauge and 25 gauge needle shape. Also, again, we are getting the Procore needles and Aqua needles coming up recently to the. We will see each of these techniques, does they make a difference or not when it comes to not only diagnostic yield, but also giving a better tissue for next generation sequencing and other molecular testing. Then there is another technique called a slow pull technique. Initially it was suction, and then now we combine slow pull technique with a fanning. So studies have also shown that slow pull combined with a fanning technique can definitely give us a better core tissue. And the next thing is intranodal forceps biopsies, where we pass a forceps into the EBUS TBNA needle and then locate it under the ultrasound guidance or a fluoroscopic guidance and see, and then get a real, whatever said and done, the fine needle biopsy needles, though they are termed as biopsy needles, they still get a core tissue. So that technically, I don't know if we can consider it as a biopsy, but the intranodal forceps, mini forceps biopsies can get real biopsies from the node. So coming to the fanning technique, again, no head-to-head comparison studies or no meta-analysis published yet in the pulmonary sector, where fanning and no fanning, does it make a difference or not? So this is one poster presentation from the chest, where they showed in an ex vivo tissue model that if you use a fanning technique, there are more larger samples with EBUS TBNA. And the limitations of this study were there is no vascularity in the ex vivo models. So we don't know how much blood contamination happens when you use this technique or not. And also sampling of multiple areas. That's a proven fact that sampling of multiple areas, especially in terms of non-small cell lung cancers, where the metastatic deposits are not focused in one area. So when there is a single sparsely distributed metastatic disease, sampling of multiple areas using this fanning technique will definitely improve the yield. Coming to the slow pull technique, this is like slow retraction of your stellate with the needle fanning in the lymph node. It's a very simple technique. So instead of suction, you just retract your stellate very slowly. So one study I will like to quote here, like they showed that in these 97 patients with hilar and mediastinal nodes, they applied standard suction in 30 patients and slow pull capillary in 56 patients, and 5 of the other patients underwent both these techniques. So the final conclusion was diagnostic accuracy was 66.67 versus 85.71 between the suction and the slow pull technique. Tissue core accuracy was obtained in 19 patients with suction, while you can see in 50 patients with slow pull capillary technique. So acquisition of tissue core was significantly associated with diagnostic EBUS TBNA, and slow pull technique yielded them more core tissues. But there is no difference in blood contamination between when you use a suction or a slow pull technique. So this is one study, but more meta-analytic data is needed to see if this really is helpful in making a difference at the end point. So this is how the next thing is the intranodal forceps biopsies. We have a few biopsies available in the market. So that goes through the EBUS TBNA channel and then take biopsy. So if you look at the data from this, when the diagnostic yield was 81% for a plain EBUS TBNA, when they combined with EBUS TBNA and the mini forceps biopsy, the diagnostic yield improved to 97%, which is very significant. Again, selection of patients is very important. Like not all patients should undergo these procedures. So we will see in what kind of patients this technique yielded more diagnosis. And these are the currently available intranodal forceps biopsies, though most of them are not available in our country. So size ranging from 0.8 mm to 1.15 mm. And then initial puncture through the bronchoscopic, through the EBUS TBNA needle, and then followed by intranodal forceps biopsies. So one more thing I would like to focus on today is something which we are new and which we are more earlier than the gastro sector when it comes to diagnosing a lymph nodes are like needle-based strategies, initial approach for lung cancer. But with EBUS TBNA, definitely there is limited amount of tissue. Some rare tumors and benign mediastinal diseases will need repeated EBUS TBNA procedures. And histopathology is always superior to site. These are all established facts. So with this concept, a new technology has been developed where a transbronchial mediastinal cryobiopsy was done. This is an early view paper which is not yet published. So in this, Professor Het and his colleagues, like they studied on 179 patients with mediastinal lesions more than 10 mm in short axis. So they used the cryoprobe. We were using cryoprobes within the airways because it gets more tissue and then you can freeze it and then get more and more tissues in the endobronchial. But this was never tried before in the transbronchial, means in the mediastinal areas where lymph nodes can be punctured through this. So the primary outcomes they wanted to see from this study was diagnostic yield comparing with the conventional TBNA and the cryo internodal forceps in cryonodal biopsies, and also looking at the procedural related adverse events. So if you look at their inclusion criteria, patients with at least one mediastinal lesion with more than or equal to 10 mm in short axis, age 15 or above, referred for a diagnosis. All patients who are referred for diagnostic bronchoscopy at two of their centers, one in Germany and one in China. And they did a CT chest or PET CT for all the patients who are undergoing these cryobiopsies. And they did biopsy in all patients, irrespective where the lesion is located. Means whichever station the lymph nodes are located, they performed procedure in all these patients. And they excluded a few conditions like mediastinal cysts and abscesses. As we know, they can cause complications. And in whom patients could not undergo a bronchoscopic procedure, or where there is a need for an additional procedure other than an EBUS that can yield a diagnosis. And this was done like at least in 73, means how they calculated the sample size was based on the previous intranodal forceps, mini forceps biopsies. So at least 73 patients they had to do. And then the procedure, all these patients underwent EBUS TBNA by an experienced bronchoscopist, and airway examination followed by ultrasound examination as a standard. And the ultrasound characters of the nodes were mentioned on a routine basis. So they did 4 EBUS TBNA passes followed by 3 cryobiopsies in all of these patients. So they described their technique like this, like a small incision was made on the airway wall adjacent to the mediastinal lesion using a hybrid knife. And then the knife was replaced by the disposable 1.1 mm cryoprobe, and then that was introduced into the lesion. They mentioned their freezing times to be 7 seconds. And also once the freezing is done, they remove the scope en bloc, like how we do the transbronchial cryobiopsies. So coming to the specimen processing, pathologists were blinded to the sequence of biopsy techniques. Rows was not routinely performed in all the patients, and pathology sample was considered diagnostic if the examination resulted in a definitive diagnosis. Suspicious findings on these biopsies or FNAs were considered as negative cases, and patients with a plausible benign diagnosis underwent a other kind of biopsy modality like mediastinoscopy or surgical lymph node VATS resection, or who were like in between, they followed some patients on a follow-up CT to rule out malignancy. And all patients, they did chest X-ray post-procedure and the routine follow-up at 4 weeks to see if there is any potential EBUS-related adverse events. Around 6 months time period, 197 patients underwent this procedure. If you look at the stations punctured, like most commonly, they punctured mostly in the 4R station, not only in the major stations like the 7, 4R, 4L, 2L, but they also mentioned their data from the 12L stations and all, so in the subsegment as well. Coming to the results of this study, definitive diagnosis was achieved in 181 patients, that is 93.3%, and 152 patients underwent both TBNA and cryobiopsy had yielded a diagnosis. 26 additional cases where TBNA failed. Cryobiopsy was able to give establish a diagnosis. In those, 6 were non-small cell lung cancers, 6 were lymphoma, 1 was seminoma, 8 TB, and then 5 sarcoma patients. And conversely, if you look at, there were patients like 3 patients who had established diagnosis with conventional EBUS TBNA, and they could not get a diagnosis on cryobiopsy. And the overall diagnostic yield for TBNA was 79.9%, and for cryobiopsy, it was 91.8%. And when they looked at the subgroup analysis, there was no difference in diagnostic yield in common lung cancers. So it was 94% for EBUS TBNA and 95% for cryobiopsy. So this procedure did not make much difference when it comes to a common lung cancer. But the diagnostic yield of mediastinal cryobiopsy was significantly higher in uncommon tumors, as mentioned above, which was 91.7% compared to the other procedure. And it also showed better results in some benign lesions where the diagnostic yield was 80% for the cryobiopsy through the EBUS scope, and then it was 53.2% for conventional EBUS TBNA. So before this paper, like we tried and did a similar kind of technique, but we did not use a knife to puncture the airway wall. So what we did in our center was like we routinely performed a bronchoscopic EBUS TBNA, and then following which we tried to introduce the disposable 1.1 mm cryoprobe through the same channel, identifying the channel where the puncture was made, and then through the same area on the bronchial wall, we introduced our 1.1 mm cryoprobe, and we, at the time of publication of this paper, we successfully did 4 procedures, and I will show you how this procedure is done. So step 1, we perform a conventional EBUS TBNA as per the standard criteria. So we use, in few of our cases, we used a 19 gauge needle, and some cases, of these 4 cases, some cases we used a 22 and a 21 gauge needle based on the availability on that day. And then we use capillary pull technique for all the patients. And then step 2, once we finish our EBUS TBNA procedure, then we perform a 1.1 mm cryobiopsy. So the probe is introduced into the EBUS TBNA scope channel, and then activation we only employed for 3 seconds. So you can see on the endosome image, the cryoprobe entering into the lymph node through the bronchial wall. And then we did not go too deep because the 1.1 mm cryoprobe, the distal portion also gets freezed. Like when you freeze for a longer, and then that can get stuck to the lymph node or the bronchial wall. So 3 seconds of freezing time, that's what we did in our place. And then we pull the scope en bloc, and then thawed in normal saline, followed by fixing in formalin. So in these 4 cases, we were able to demonstrate, maybe 1 or 2 cases, all the cases. Yeah, so both cryobiopsy and EBUS TBNA demonstrated diagnosis in all the 4 cases, and we were also able to perform ALK ROS analysis on these cryobiopsy specimens. So I would like to conclude by saying there are many techniques to acquire adequate tissue. Most importantly, more than what kind of needle or what kind of method you are using, a pre-procedural discussion with the pathologist will play a major role in diagnosis and also in further care of patients. And we should also move to putting more focus on preserving the FNA slides, as the new studies are showing that they are more having more material for genetic analysis, because once you fix in formalin and then make a block, most of these DNA gets washed away. So we also should focus on giving more importance to the slides, and FNB needles will need to be studied more in benign diseases as well in Indian settings. So EBUS with cryo is a very promising and exciting technique, which will need more validation in terms of patient selection. Will be able to
long क्यों गया, लंबा क्यों गया इनका?
Thank you.